I want to thank the organizers of this two-day workshop on the rehabilitation and community integration of persons with psychiatric disabilities, the first 10 years and beyond, for granting me the privilege of introducing two national and international leaders in the field of psychiatric rehabilitation. There's a Talmudic saying that reverses the usual hierarchical process of learning. According to this saying, we learn something from our teachers. I hope some of my students learn something from me. A bit more from our friends, but we learn the most from our students. In a sense, in comparison to the United Kingdom and the United States, with their relatively longer history of involvement with the systematic provision of psychiatric rehabilitation services, the Israelis, we, are the students, and our distinguished guests are the teachers. Despite our pride in Israel's accomplishment in improving services for persons with severe mental illness due to the new law, I am confident that we possess the humility. I am confident we possess the humility. All right, that to learn from our teachers. I also would like to know if, in accordance with the above mentioned Talmudic saying, they can learn anything from us during this and other sessions. So let me introduce our teachers. I want to introduce our teachers, our distinguished teachers. The first speaker will be Dr. Michael Hogan, who is a commissioner of mental health in New York, and he's been a commissioner since 2007. The New York State Office of Mental Health operates 25 accredited psychiatric hospitals and oversees New York's $5 billion public mental health system that serves 650,000 individuals annually. Dr. Hogan serves as director of the Ohio Department of Mental Health. He has served in the past and was the commissioner of the Connecticut Department of Mental Health from 1987 to 1991. He chaired the President's New Freedom Commission on Mental Health in 2002 and 2003. Anybody who's acquainted with the literature on psychiatric rehabilitation knows the revolution that particular commission made. He served on the National Institute of Mental Health's National Advisory Mental Health Council as president of the National Association of State Mental Health Program Directors and as board president of the National, a long abbreviation here, so I won't say it, but he has received leadership awards from the National Governors Association, the National Alliance on Mental Illness, the Campaign for Mental Health Reform, the American College of Mental Health Administration, and the American Psychiatric Association. Wow, that's a lot of things, important stuff that this man, and he came all the way to help us learn from him, and I hope that maybe we can provide a little bit of that in return. So I invite Dr. Michael Hogan to talk about.
I will confess that this topic of integrating services is something that I understood very well about 30 years ago. And then I started doing it, and I found out that everything that I knew, and I could give very impressive lectures about it, was not very helpful in terms of actually doing it. So I come with the qualification of having forgotten a great deal. I will say that it's very bad form to correct a person who was given such a generous introduction, but I feel that in many ways, with this law, Israel has surpassed anything that many other countries have done, certainly in the United States. There's no state in the United States that has a law that provides, whether it is an entitlement to services or whether it's merely an enthusiastic promise of services. There's no law in the United States that has gone that's gone that far. So I also confess to considerable uncertainty about the context of your work. I somewhat understand the context of my work, but I don't understand the context of yours. So it's a little bit impertinent to give a lecture from that vantage point. I'm reminded of the organizational scientist Chris Argyris, who said in thinking about the application of controlled research studies to organizational life, that because organizational life is made up entirely of relationships and context, that controlled studies that are designed to take all the context away are precisely inapplicable. So perhaps a lot of what I'll have to say will be precisely inapplicable, but you will have to figure out which is inapplicable and which has some relevance. So I'm going to just give an overview here of what I want to try to cover. To say, first of all, that clearly care in many countries has been transformed over the past quarter century or half a century. And it has, one of the forms of this transformation has been a movement from hospital to community. This movement has clearly provided more freedom for people, which we value, and also more opportunities for recovery, because you can't very well learn to live in the community if you're not living in the community. Len Stein, one of the fathers of American community psychiatry, has said that to try to rehabilitate people in a hospital would be a little bit like teaching tennis on ice skates. So if somebody is in the community, one has the opportunity to succeed, but also the opportunity to fail. But it provides the opportunity for practice. But although the movement from hospital to community was the right thing to do and provides opportunity for recovery, it has de facto created more fragmentation. And so we have terms like falling through the cracks. Every layperson knows the term falling through the cracks, and they use that term when somebody that we're responsible for doesn't get the care that they need. And I also am reminded of the book by Susan Sheehan, tracing the life of a woman who lived in New York City with schizophrenia, and the title of the book says it all: "Is There No Place on Earth for Me?" So this transformation has created challenges. I want to illustrate that just a little bit. And then second, I want to turn to this question of whether care can be coordinated. In the United States, it cannot. We have a system in the United States that's set up to defeat the premise of coordinating care, which makes me wonder why you've thought to have me come talk to you about this at all. But we do have some ideas or strategies about how to approach it, even if we're not very good at it. And I do want to suggest that this emerging, sometimes controversial, but ultimately helpful paradigm of recovery changes the challenge, and I believe creates opportunities for better coordination of care. So first of all, just as a measure from the states of how care has transformed, this is quite a similar slide to what Yuri provided before. We see that over this period from 1981 to 2006, and this is the combined budget of all the state mental health agencies, and the states in the U.S. are ultimately responsible for mental health care, that we have moved from a system of care that was 2/3 of the money in hospital to now more than 2/3 of the money in community. So the care was transformed, but that has created more challenges than solutions with respect to how to coordinate it. After all, in the asylum, in the psychiatric hospital, this is just a picture of the what was called the Central Ohio Lunatic Asylum in Columbus, Ohio. All care was under one roof, and health care and psychiatric treatment and housing and rehabilitation, to the extent there was any, was provided under one roof and under the authority of one superintendent. A much more, the wrong setting in a sense to learn how to live in the community, but a setting in which coordination of care was feasible. And if we compare that with living in communities and the many services that might be available or that might not be available and people might need, this problem of how to coordinate services, how to coordinate rehabilitation, and other health and social services becomes very much more complex. One of the theories about coordinating care that we had in the United States was the invention, and forgive the alphabet soup, American alphabet soup, that the Community Mental Health Center would be a vehicle for coordinating care. This was the theory of the Community Mental Health Centers legislation, which President Kennedy succeeded in getting passed in 1963. It really was a turning point in this movement from institutional to community care. So the theory, in a sense, that we would have a federal agency, this is the Substance Abuse Mental Health Services Administration, and they would lead the state departments of mental health. And then in communities, we would have these community mental health centers, and people would have a wide array of services. It looks like a market basket, I guess, coordinated for the individual consumer by a case manager. But in the United States, the way we approached this problem was that there were not enough opportunities, there were not enough places for people to live, there were not enough job support programs. And rather than create those in a single rehabilitation market basket, those are created by and large through different governmental programs. And so what we had was different federal agencies assuming responsibility to work with different state agencies and to create different programs. And you can see the money flows in all these different ways, and a system is created that is so complicated that nobody can describe it. And the consumer and the family have the problem of ultimately coordinating all this. So we created all these many opportunities, but it became very much more fragmented in the process. Now, one would think with that picture of fragmentation, and since this simple term of falling through the cracks, since that is on everybody's tongue, you would think that there would be an impetus to coordinate services better. You'd think that it would demand action, but not so much. There is a long history in the United States of resisting an effort to integrate or coordinate or better manage care. And here is an example of that. This is specifically for Dr. Avram, and he'll have to explain to you what this reference means. But one of the earliest efforts to achieve integrated care or to establish responsibility, which is something that has to be done before care can be integrated, is way back in 1854, the Congress of the United States, both houses, passed legislation to create a national program of mental health care. Of course, at that time, the approach to care was hospitals, termed asylums. And so this program was passed by the Congress so that the federal government would help all the states build psychiatric hospitals. And President Franklin Pierce vetoed this legislation. This is part of his veto message. Whether the federal government should enter into a novel and vast field of legislation providing for this particular class, but as President Pierce said, does this mean that then anybody with any kind of calamity could come along and the federal government would have to take on that responsibility? So fearing all this, he vetoed this legislation, which to some extent, from where I sit, has led to a very long tradition of the federal government in the United States not really accepting leadership responsibility in any way for mental health care. Indeed, it's led a couple of political scientists at Yale, Ted Marmer and Karen Gill, to say that because the American political system is set up to resist the consolidation and centralization of power, we have this system of checks and balances with the courts and with the judiciary, and the federal government has certain powers, but the states retain other powers. Because we have a system of government that is intentionally fragmented, meeting the needs of people who require coordinated care is highly unlikely. So they essentially said, from a political theory point of view, don't look to the United States for solutions to this problem. So my presentation is done now. No, not quite. So this problem of coordination is built into, or the resistance to coordination is built into the American system. So I want to take a little digression now and go off and look at, in a broader way at trends in mental health care in the United States. This sort of goes beyond our core topic here, which is looking at the Rehabilitation Act, but beginning to look at some of those questions that have started to come out in conversation. What about the HMOs? What about the role of other health and social services? Can the rehabilitation problem be solved within the rehabilitation law or not? So this is a fascinating, I think, the best text in mental health policy in the last 50 years by several colleagues, Richard Frank and Sherry Gleed. Richard at Harvard and Sherry at Columbia. Both of them now, interestingly, are working in the federal government on loan from their respective institutions. So maybe they'll fix this, although I'm not expecting it. So they set out to answer the question of, are people with a mental illness in the United States better off today than they were 50 years ago? And if so, why? Are they better off or not? And if so, why? The answer to the question is the title of the book. People are better, but not well. And I want to illustrate some of this a little bit. But first I want to plant the primary question that they raise in thinking about the causes of this improvement. And the question is, does the better strategy turn out to be the mainstreaming of people and the mainstreaming of policy so that people with a mental illness have better access to overall benefits and services in the larger community, access to health care, which, as you know, remains a problem in the United States, access to social resources, social insurance in particular, not a strength also of the United States. So is well-being changed by access to general benefits, the theory of mainstreaming, or is well-being primarily improved through what they call exceptionalism, which is the Rehabilitation Act? That is special circumstances for special people. Now, I've already kind of said that in the United States, the political system is set up to defeat an approach like the Rehabilitation Act. It's just impossible to me that in our system of government we could achieve legislation such as you have achieved. But nonetheless, this is what they find out in looking at mental health care in the United States. First of all, they find that many more people now have health insurance that provides for some of their mental health care. So this is just a chart from 1971 and then 30 years later, looking at all the payment for mental health care and where the payment came from. And you see this category here at the top, OOP is not OOPS. OOP is out of pocket. So out of pocket is payment for care that people directly take out of their wallet to give to the caregiver. And so then you see the other categories here, private insurance, these federal programs and so on. And so what you see here is a trend that much more payment for mental health care has come from these sources, which back in 1971 were relatively small and have now become relatively large. And so you can see that now much more mental health care is paid for by insurance, as it should be, and less is paid for out of pocket. So people are somewhat better off with respect to coverage for mental health care. This has led to a reduced financial burden of those who get care. And so you see in different categories here, and I apologize that the captions are not that clear, visits to a doctor, visits to non-MDs, a psychologist, a counselor, a therapist. RX is medication treatment or payment for going to a psychiatric hospital. And what you see in all these areas, but particularly for visits to therapists, for drug benefits, or for hospital services, a dramatic reduction and a trend toward more care, again, being paid for by insurance. This has led to more people getting treatment. So we have Ron Kessler's two studies of patterns of mental health care in the United States, one from 1990 to 92, these green bars, and the second is 2001, 2003, just 10 years later. So here you have the percentage of the overall population who gets any care, the percentage with a disorder, or we focus over here on the people who have a serious mental illness who get care. And so what you see is a dramatic increase in the percentage of the population, and we are still concerned about those over here who have a serious illness who get care. Now, we still note that less than half of all people with serious mental illness get any treatment for it in the United States. But still, there's been an expansion in care, even though too often the care that they get is not enough care, and it's not very good. As a matter of fact, it turns out that if you analyze this difference over here, and Mark Olfson at Columbia has looked at this, it turns out that most of the increase in people getting care is people who do not go to a psychiatrist or a therapist, but go to a general practitioner and get a prescription for an SSRI, Paxil, Prozac, and so on. They don't get psychotherapy, they just get the prescription, and they tend to stay on it for 1 month or two and then go off. So this is an interesting object lesson, that the expansion in care, I think it's related to several things, partly related to stigma. So people are willing to talk to their GP about, I'm not feeling so good. They're particularly willing to do that if they're seeing ads on TV that say, you don't have to feel miserable, ask your doctor about Prozac. Turns out. As a matter of fact, the treatment rate for depression has gone down a little bit in the last few years because these medications are going off patent, and so consequently, the drug companies aren't advertising them. So less people are asking about them and less people are getting treatment. But more people are getting something in the States, even though it may not be enough, may not be exactly the right stuff, and there may not be enough of it. So we see these trends. More people are getting some care. More of the care is paid for by private insurance. And here what we see is this is the overall trend in health spending in the United States. So if we keep this going for another 30 or 40 years, all spending in the United States will be for health care. There'll be nothing else. We're now up to, what here? Well, this is, I guess, per capita dollars, but we're now up to 18% of GDP being spent on health care, but not for mental health care. The percentage of health care that goes to mental health care is essentially flat at about 1% of GDP. So somehow access has been a little bit expanded, insurance benefits have increased, more people are getting something, even if it's not great, and it's not costing society relatively any more money. So another trend over this period, we look here from 1970 to 2000, where are people living? And again, I apologize that the captioning is not so clear. So these are people with a serious mental illness. These are people who would qualify for the rehabilitation basket here in Israel. And we see that most are living in the community. NOC is not otherwise counted. So they're living somewhere in the community on their own or with other friends. But they're living independently. We see a greater proportion, and fewer people are living in institutions, so this is mostly psychiatric hospitals, or in these rooming houses and so on that are a cheap but not very good place for people to live. So the good news here is that fewer people are living in not so good places. There's a dark side of this, of course, if you follow the United States, and that is up here. So what about the people who appear to be living nowhere? And so you know where this is going to go. The number of people who are in fact living nowhere because they're on the streets or homeless, or those who are incarcerated, has increased over this period of time. So most appear to be doing a little bit better. Some are not doing well at all. So looking at this macro picture of mental health care in the United States, Richard and Sherry conclude that people with a mental illness are better off but not well off. That in the States, these advances I primarily due to mainstreaming. That is, access to broader benefits appears to what has helped people as opposed to a strategy of exceptionalism. So being included in health reform and insurance expansion and having access to social benefits, both areas where the United States does not compare very favorably to Israel or a lot of other democracies, has assisted people rather than advances in exceptionalism like special benefits and services, which are available to people with intellectual disabilities in the United States, but not to people with a mental illness, and not primarily due to improvements in mental health treatment. So then the question is, what does this apply for Israel, a very different country with a very different social welfare and health system? So one of the things that occurs to me as a challenge that I don't know the answer to is that this data does suggest that one of the frontiers for you, while the Rehabilitation Act is an immediate concern, and what about the next 10 years? There are some possibilities to improve services in HMO and in social services, but I don't know what the path to doing that is going to be. So these are the people who maybe are at 30% disability, or the people that have just come into hospital for a psychotic disorder, but they're in that 30% who don't come back, or maybe they're in the next 30% who need something, but not necessarily the whole rehabilitation package. And then the question is that the challenge of integrating care remains serious, of integrating rehabilitation and other services. Are there any other trends? Do I have anything other to say that's helpful in that regard? So I want to talk a little bit about what I see as the possible benefits of a recovery approach to this, to the possibilities here. So first, it seems to me that a recovery model, and I'll illustrate this a little bit, provides the opportunity to focus early on potentially serious disorders. In a sense, the notion of starting rehabilitation early on with somebody who's likely to become disabled as opposed to having to wait. And second, I'll talk about this other dimension of recovery, one dimension being people get better, but the other dimension of people wanting to live their own lives in their own way, which came up so clearly and so well in Mr. Krzyzewski's remarks. And this second notion that we haven't gone as far perhaps as we can with respect to person-centered care in two ways. One is a recovery orientation, but the second to use data in different ways to fill the cracks, especially to fill cracks for people whose services are very chaotic. So to just come back to this point, and I showed this slide the other day, that focuses on, these are 5 of the roughly dozen very long-term studies of people with schizophrenia followed up on over a very long period of time. And what's interesting about this very long follow-up is we usually don't follow people for a long period of time. We might follow them for a few years. So we know that in the next few years after hospitalization, 30% may come back. Well, these numbers are all a lot better than 30%. And interestingly, most of these numbers, in terms of the percentage of these individuals who were significantly recovered, were not in environments that offered good rehabilitation programs. So one of the challenges for us is to think about how can it be true and what are the implications that so many people improved so much without access to good rehabilitation programs. Interestingly, of all these studies, the only program that I know of where rehabilitation was a significant part of the package was this last study, the Vermont study, where the patients in this case, the 269 people, were discharged from the back wards of Vermont State Hospital, but discharged through a very well-structured, community-oriented rehabilitation program. So the question of whether rehabilitation for people that are very disabled increases the rate of recovery is certainly relevant for us. So a first meaning of recovery is that many people can get better. As a matter of fact, this is a slide that I just put in to remind myself of this point, one of the nicest parts of the President's Commission in 2002, 2003 was the opportunity for a conversation with Mrs. Rosalind Carter, the former First Lady who chaired the last President's Commission in 1977, 1978, 25 years ago. So Mrs. Carter reflected with us on what had changed in the mental health landscape in the United States over the last 25 years. And she said to us, you know, I think there's one change that is more important than all the other changes in mental health care, and it was that today we know that it's possible for any person to recover. Possible for any person to recover. Not that every person will recover. Still, we know that some people won't. But what's important about this is we cannot know who the people are who will recover significantly and who won't. We don't know what that is. Or in a different way, we cannot give up on anybody. The person who today is hopelessly psychotic, it seems, and out of touch with reality, and no treatments have worked, a year from now may be living at home. And we don't necessarily know why that's going on. So hope and recovery are being important. So the next meaning of recovery that it seems to me is more important than the first, that people can get better, is the meaning of recovery that Bill Anthony wrote about in 1992 that primarily comes from the lived experiences of people with serious mental illness who have reflected on their experience. And these individuals have taught us that recovery, being the process of being in recovery, is more of a process than a destination. So somebody can be in a process of recovery without being all better. They still may relapse. They still may have problems. But if they see themselves and define themselves as being on this journey, their life can get better, even though their conditions or their symptoms may not completely remit. So we professionals tended to think about this primarily in terms of symptoms and symptomatic related outcomes, but by and large our customers have focused on this as a different way of living a life of being in recovery rather than a life of achieving recovery. This is the definition that the federal government in the United States has come up with on reflecting that. So this is what they call a consensus national definition of recovery in the states. And you sort of see that this notion of a journey of healing and of transformation leading to a meaningful life that recognizes that there may be still significant illness and disability. Now, if we think about recovery that way, not just as getting all better, but if we think about recovery as a journey, it seems to me, require a new approach to care, and it's a new approach that I hear emerging in your rehabilitation programs here. And I'll illustrate this with a sort of an unusual source, President Bush. This is a quote from the executive order that President Bush signed to create the President's Commission in 2002, 2003. The first time I read this, I was quite struck. So that a president of the United States would say that the goal of this commission, which is really, in a sense, the goal of the mental health system, is to recommend improvements to enable adults with serious mental illness and children with severe emotional disturbance to live, work, learn, and participate fully in their communities. And what I was struck by is this is almost exactly what people say when they come to us for help. What families say, what consumers say, is they want this. As Charlie Curry, the administrator of SAMHSA, used to say, a job, a home, and a date on the weekends is what people are looking for, not to go to program, not to take their meds, not even necessarily, yes, relief from symptoms would be good, but these are by and large the goals that people bring to us. So it made me think, if this is what the president is saying and this is what the consumers are saying, what should we be saying? And it calls us, it seems to me, to begin to think in our process of care about these outcomes as the primary outcomes. This is being translated in the States, or we hope that is being translated into an approach which is long overdue, and that is much more both affirmative and early approach to people with psychotic illness. The RAISE, R-A-I-S-E, is the name of this big research project, Recovery After Initial Schizophrenia Episode. And these slides look different because I've sort of stolen them from the National Institute of Mental Health. So their description of this paradigm suggests one of the challenges for you in Israel, and that is to move rehabilitation or to move the approach to treatment in the mainstream health system and in hospitals toward an early, a first episode approach, as opposed to requiring that people achieve a substantial degree of disability in order to get rehabilitation. So this description, which is a US description, sounds as if it might be not entirely inapplicable to the Rehabilitation Act. Focus on managed, established illness and disability, although your sights are higher than that. You want people to achieve a life. But an alternative approach to think about, not one widely practiced in the United States. In the United States, our typical model is let people fail many times, and then we'll try something else. But to see whether early treatment and rehabilitation can slow or halt or maybe even prevent disability for people with an initial psychotic episode. So here is the complicated NIMH picture of this. We usually have people who are doing pretty well before they get sick. Their behavioral adaptation is high. Their psychotic symptoms are low. I think I've worn this out. And then they have their first break. They slide a lot. We almost always stabilize people very well from their first episode of psychosis. In a week or a month, they're doing much better, and we let them out of the hospital, but we don't stay with them. We don't start rehabilitation right away. We don't hang on to them in terms of their condition, and they have these different patterns of failure. And the question arises of whether we can get with people right in the first episode. We can get them back through let's say, a basket of care to a level of functioning and a satisfaction of life that's very high. So this is a too complicated slide of the approach to this project that, as a matter of fact, Bob Drake is helping advise us on this, that we're going to try to use to essentially, the way that I would describe this is a rehabilitation and recovery-oriented approach very early on in the experience of psychotic illness. So we start with a person whose job title would be a recovery specialist. And we would reach out to people the first time that they're in the hospital and try to connect them with medication treatment, with supported employment, an explicitly rehabilitation-oriented service, or supported education right away, as opposed to waiting until they get disabled, to help them with the behavioral skills that they need to understand when the way I'm feeling is an early precursor of sliding into psychosis again, so I can do something about that right now. Support and education to the family, usually forgotten, to bring in peer support of somebody who's experienced the similar condition and can talk about that right away, working toward this goal of recovery. So I've slipped away from my assignment to talk about care coordination, but one of the things that I focus on here is that in this kind of a person-centered approach, care coordination is built into the intervention itself. So I'm going to close with a couple of thoughts about another approach to care coordination that is starting to emerge in the States, and that has to do with the people that are having the worst results. Not necessarily the people that are stuck in the hospital, but the people that are in our communities cycling in and out of hospital, using alcohol or drugs, coming into the emergency room or crisis centers with all kinds of problems and so on. So what we're finding now is by looking at patterns of individuals, patterns of interactions that different people have with the healthcare system, it's easy to identify those people that are having the worst time. And then to create a team, to put a team together with them that is not necessarily just the care team, but is also a care monitoring team to track them, to develop an approach to care that is more continuous and recovery oriented. So this is another illustration of how this kind of approach to mental health care has an impact in the larger health system. So this is one of the focuses in this focal points in the states of healthcare reform, of how to, as they say, bend the curve of these constantly rising expenditures, and that is to prevent readmissions to hospital. So the term is a potentially preventable readmission, which is a readmission to hospital that occurs because the care wasn't good. The person was discharged too early, or was discharged from hospital care without good and linked follow-up. Obviously, some people can have a readmission because their illness just remains out of control or it spikes again, and there's nothing that we reasonably could have done to prevent that. But an early analysis of this in New York State found $813 million in potentially preventable readmissions in 1 year. And what was interesting about this is most of these readmissions were for people with a mental health condition, but they were readmissions for medical problems. In other words, this is saying how the medical system needs our support to better care for people and reduce its cost. So only a small proportion of these readmissions were for people with no mental health problems or no substance abuse problems, but just readmission for a medical problem. A considerable portion was people with a mental health or substance abuse diagnosis who were readmitted for that problem. Most of the costs were people who have a mental health or substance abuse problem whose readmission was for a medical problem, for diabetes, for hypertension, for the flare-up of other medical conditions, where the fact that we weren't providing good care for their depression may have been what led to stopping, not just not taking their antidepressant anymore, but not monitoring their blood sugar. And the approach here is to first use technology to identify these people who are cycling through care, and then to create a personal plan used in the hand of a team to coordinate their care. So this is just a little example of that from a program in New York State. This is New York City down here. This is the state overall. And this is a care coordination program in several counties, Erie, which is Buffalo, New York, and Monroe, which is Rochester, New York. So one of the things that these counties found in looking at their people with serious mental illness is that that 10% of individuals who were using the most services were using 63% of all of the hospital and residential spending. So a very small number of people was leading to very high health costs and residential care costs, but that most of these people were not enrolled in a program designed to really coordinate their care. These are different kinds of case management. And so creating a team-based care program for them, which has some of these elements, a recovery focus, sitting down with them to develop a life plan, a heavy involvement of nursing to try to coordinate care, has had pretty dramatic impact. And again, these are the people with the worst outcomes. So decrease in emergency room visits, days in hospital, better health outcomes on the part of these individuals, and better social outcomes for them as well. So my thought about this is that while I think you face some challenges in thinking through the next 10 years just within the Rehabilitation Act, it may be that the bigger challenges are how to extend the benefits of rehabilitation to people that don't need it quite so much, to maybe prevent them from having to achieve a significant degree of disability. So my final thoughts in closing that the movement from hospital to community was the right thing to do, but that the care coordination became more complex, and particularly in the States, we never did a very good job of it. This is in part because we tended to invent new programs as opposed to thinking about ways to provide more integrated care. And as I've said several times, a government like the US government with divided powers makes the coordination of care much more difficult. So your achievement here of a Focused Rehabilitation Act is really a signal accomplishment. The recovery model does offer, I think, continued opportunities. That better alignment and a focus on the consumer's goals is going to help us in the long run. What the science says is the right approach to care for them. What our own skills are to try to engage them in care. Motivational interviewing, for example, to ask them whether they're satisfied with the life that they're living, which is probably producing many bad experiences for them. And finally, to find out what their preferences are for care. But there are these opportunities to achieve better alignment, and also the fact that people who start on a journey of recovery are in a better position to manage their own affairs. And finally, that the technology of care coordination will help us to plug the gaps for the people who are most in need. Thank you.